The next situation where one might worry about TB in children is the setting of the so-called contact investigation. When an individual is found to have TB, they should be reported to the local health department within 1 working day. One of the jobs of the health department is to try to figure out who else in the patient's life might be infected. In health department terminology, this is called the contact investigation. Young children are a very high priority during this evaluation because they're more likely than older children or adults to develop active TB, and may do so within weeks of becoming infected. All contacts of a contagious case of TB should undergo screening by skin testing and questioning about TB symptoms. Children under 5 years of age who are contacts to a contagious case should also immediately have chest radiographs taken and undergo history and physical exam. This allows for the most efficient identification and treatment of a child with early TB. You should not wait for a positive TST result before performing this evaluation on a young child, or in fact anyone who is otherwise immunocompromised or symptomatic. Once a child contact is determined to not have TB, he or she should be considered for LTBI treatment regardless of the TST or IGRA result. If the TST or IGRA is positive, this treatment is the beginning of the course for LTBI. If the TST or IGRA is negative, especially in child contacts under 5 years of age, the treatment is considered to be window prophylaxis. The window period is the early period of immune processing when the child might be infected, but the skin test or IGRA is not yet positive. It typically takes 2 to 8 weeks after infection before the delayed type hypersensitivity response becomes evident. The young child contact should receive latent TB infection treatment during the so-called window period. The goal is to abort an early infection if the child has inhaled Mycobacterium tuberculosis bacilli and to prevent the possibility of rapid progression to TB. After 8 to 10 weeks or so of no further exposure to the contagious case, the child should undergo a repeat TST or IGRA. If the test is still negative and the child is immunocompetent and has no new symptoms concerning for TB, the treatment can be stopped and no further evaluation is required. However, if in fact the original source case has been contagious and still exposing the child, or if another adult is found to have TB in the child's environment, the evaluation may need to be repeated and/or treatment extended. If the child's TST or IGRA becomes positive upon repeat testing, the LTBI treatment should be completed. If the child does not have concerning symptoms, a repeat chest radiograph is not necessary. The older child is treated a little bit differently. Because children over 4 years of age are less likely to develop TB once infected and are less likely to quickly disseminate their TB, their evaluation and treatment can be personalized a bit. Older children exposed to TB should also be tested, and the family should be questioned about symptoms. If the TB test is negative and the child has no concerning symptoms, it is not imperative to perform a chest radiograph. The use of window prophylaxis is individualized based on the extent and intimacy of the contact and the contagiousness of the source case. Your local health department will guide you through the use of window prophylaxis for each family. Whether or not window prophylaxis is initiated, it is important to repeat the TB test approximately 8 to 10 weeks after the contact is broken or the source case is deemed to be non-contagious. If the TB test is now positive, obtain a chest radiograph if it was not performed initially. To sum up the key concepts regarding children identified during a contact investigation, in layman's terms, kids exposed to someone with contagious TB. All children, and in fact all individuals with significant exposure to a contagious TB case, should undergo prompt TB testing and symptom review. Children under 5 should also have a chest radiograph performed even before the TB test results are available. If the young child does not have TB, window prophylaxis should be started, independent of the TB test result. This treatment may abort an early TB infection and/or treat early LTBI and prevent the rapid progression to TB. 8 to 10 weeks after exposure to the contagious case is ended, contacts should undergo repeat TB testing. If the TB test is still negative, the window prophylaxis can be stopped, assuming the child is immunocompetent and capable of generating a positive delayed type hypersensitivity response. The final common situation where we would worry about the possibility of pediatric TB is the evaluation of clinical symptoms or radiographic abnormalities. In children, it's difficult to distinguish the radiographic findings of community-acquired pneumonia or asthma from those seen with TB. Complicating the diagnosis of TB in children is the fact that their symptoms are often subtle or even absent. Additionally, TB in children is difficult to confirm microbiologically. Young children cannot produce sputa easily, and their sputa are almost always smear negative, meaning it has relatively few bacilli compared to adult sputum. So we must rely on several other features to diagnose TB in children. The following circumstances would increase my suspicion of TB disease in a child with an abnormal radiograph or who is symptomatic. Exposure to a person with TB, several people in the child's environment with positive TB tests, radiographic changes common in pediatric TB, including intrathoracic adenopathy and calcified granulomata, and finally, a relative paucity or chronicity of symptoms in comparison to the radiographic changes. In areas of high TB rates, TB will appear more often in the differential diagnosis and more TB tests will be performed. Unfortunately, a positive TB test does not confirm the diagnosis of TB in a symptomatic child, and a negative TB test does not exclude TB. The results of the TB test are merely one more factor to include in the equation. This busy slide illustrates my general approach to the child with a positive TB test and radiographic abnormalities that may or may not be caused by TB. Before I go through this algorithm, let me say that if I am seeing a child who is exposed to an active case of TB, I am always going to err on the side of culturing and treating for TB, because the likelihood of TB goes way up. This slide is more for the child who is somewhat less likely to have TB. Starting at the top of the slide, the patient in question is a child with a positive TB test and an abnormal radiograph or symptoms. Always try to identify a potential source case, and if the child is hospitalized, use appropriate airborne precautions until you're sure that the child and their adult visitors are not contagious. Limit visitors to those who have been screened and are not contagious. If the findings are more consistent with another diagnosis, we go over to the right-hand side of the algorithm. One example might be peribronchial cuffing and atelectasis on chest radiograph and wheezing on exam. In this case, the diagnosis is more likely to be viral bronchiolitis or asthma. Another example is a child with acute onset of cough and high fever with lobar pneumonia. The diagnosis is more likely to be community-acquired pneumonia. In these situations, even though the patient has a positive TB test and an abnormal chest radiograph, if the patient is very stable, I would consider collecting TB cultures by sputum induction or gastric aspiration. And I would treat the more likely diagnosis by use of antibiotics and bronchodilators. I would not treat with rifampin or isoniazid alone for latent TB infection during the evaluation in case this is actually TB. It is important in this scenario to reassess frequently. If the patient improves clinically, repeat the radiograph in 1 to 3 weeks. If the radiograph normalizes without TB treatment, you can conclude that the patient actually had some other lung pathology and concurrent LTBI. Only at this point should you treat for LTBI. If at the end of this period of close monitoring, the patient's findings do not normalize and TB continues to be a likely diagnosis, collect cultures if you haven't already done so, and start multi-drug TB therapy. What if the patient is not very medically stable? For example, an immunocompromised child or a child with meningitis. In that case, I would submit specimens for cultures and start TB therapy, knowing that sometimes I will overtreat for TB. In these situations, the diagnosis occasionally becomes clear over the ensuing days or weeks, and I can either stop the TB therapy or finish the course confidently. Sometimes the diagnosis doesn't become clear, and I'm compelled to complete the treatment for TB. No one ever wants to treat a child with multi-drug TB therapy for 6 or more months unnecessarily, but sometimes all one can do is weigh all the likely diagnoses, consider the risks and benefits, and make the best judgment after discussion with the family and expert resources. The middle of the slide describes the situation where TB is the most likely diagnosis. Examples would be children with intrathoracic lymphadenopathy, with or without airspace disease, or children with a relative paucity of signs and symptoms compared to their radiographic abnormalities. Consistent exposure history, such as contact with a contagious case or previous residence or travel to a TB endemic area, increases your confidence in this area. Another common situation is the evaluation of a child with an enlarged peripheral lymph node and a positive TB test. Scrofula is the name that we use to describe peripheral mycobacterial lymph nodes. These nodes typically enlarge over a matter of weeks and are not particularly tender unless they enlarge quickly. Over time, the overlying skin discolors, first pink, then somewhat dusky or purplish. This is different than the rapid development of red color and marked tenderness seen with pyogenic lymph nodes. The good news is that children with TB scrofula nearly always have a positive TB test, unlike children with primary pulmonary TB or meningitis, who not uncommonly have a negative TB test. See the resource material for more information about evaluation and treatment of subacute lymphadenitis. Here's my Reader's Digest version. The features that distinguish TB scrofula are: TB scrofula tends to occur in children over 5 years of age and in children who have TB exposure or at least TB risk factors, including travel to endemic areas and consumption of unpasteurized dairy products which might carry M. bovis, one of the MTB complex organisms. TB scrofula is most often in the cervical chains, but could be anywhere in the body, and it tends to be associated with larger TST induration. Non-tuberculous or atypical mycobacterial adenitis is more likely in children less than 5 years of age and occurs more frequently in the submandibular and submental lymph node chains. Cat scratch disease causes lymphadenitis with nearly the same presentation, but more commonly occurs in the axilla and groin. Exposure to kittens and history of scratches are common. Let's turn now to a situation where there is clinical suspicion of TB, but the TB test is negative. Remember, a negative TB test never rules out TB. Roughly 20% of culture-proven pediatric TB cases are TST negative when they are initially evaluated. This is most common early in the infection and with extensive or disseminated disease. If the TB test is negative, you would still pursue the diagnosis and treatment of TB, especially in the child who has a known source case and/or radiographic abnormalities most consistent with TB. When I say most consistent with TB, I mean that the clinical findings are generally subtle or more modest than the radiographic findings, or that the radiographic changes might include intrathoracic lymphadenopathy, which is very common in pediatric tuberculosis. The next subject I'd like to briefly cover is the collection of cultures for TB in pediatric patients. Sputum is the most commonly cultured specimen from adults. Older children can be taught to collect sputum by induction with nebulized saline or at home, in the shower, or just by practicing. The highest yield specimen for infants is the gastric aspirate. After an overnight fast, the young child's stomach is intubated and contents are aspirated. 3 consecutive morning aspirates have approximately 50% yield in children with TB. See the resources section for a website containing more details and a video demonstration. Other possible specimens include cerebrospinal fluid, lymph node tissue, blood, urine, bone biopsy, and synovial fluid. Remember to submit specimens in a sterile container without formalin, not on swabs, and to submit as large a volume as possible. To summarize, not everyone with a positive TB test and clinical or radiographic abnormalities has TB, and not everyone with TB has a positive TB test. Makes it a little challenging, doesn't it? In your diagnostic approach, consider TB exposure, TB test results, nature of the signs and symptoms, and the radiographic features of the patient when deciding how likely it is that a child has TB. Test for other likely diagnoses. A therapeutic trial of bronchodilator therapy or a single course of antibiotics for community-acquired pneumonia sometimes clarifies the diagnosis. This strategy should only be used for very stable, immunocompetent patients who will not be lost to follow-up. Since pediatric specimens are almost always smear negative and cultures are positive only about 50% of the time and don't provide a result for at least a few weeks, you'll need to weigh all these factors when deciding to take the plunge and start TB therapy. Don't forget, you're not alone. If at all possible, children should be managed at a dedicated TB clinic. If there's no such clinic available to your patient, take advantage of the many pediatric TB experts who consult regularly by phone and email. We're here to help.